All right, so we are moving on to not really a disease, but more of a condition. And so this is called disseminated intravascular coagulation, also known as DIC. And DIC is I'm going to use the word grave here, okay? It's a grave blood coagulation disorder that occurs as a complication of conditions that accelerate clotting, okay? Basically, what's happening here is you have small blood vessel occlusion, organ necrosis, depletion of circulating clotting factors and platelets, and activation of the fibrinolytic system, which is your blood clotting promoting system. So what happens is these processes are going to provoke a severe hemorrhage as clotting factors are consumed. So clotting in the microcirculation usually affects the kidneys and extremities, but it can also occur in the brain, the lungs, the pituitary, the adrenal glands, and the GI system. And although it's usually acute, DIC may be chronic in your cancer patients. And prognosis is going to depend on early detection and treatment, hemorrhage severity, and the treatment of the underlying disease. So where people get confused here is that people always think that this is a bleeding problem, okay? It is a clotting problem, all right? So I'm gonna say this as simply as I can. So something has happened to where you have accelerated clotting, and basically what happens is the patient uses up all their clotting factors, okay? When all the clotting factors are gone, then the patient bleeds out, okay? So it starts off as a clotting problem and then it becomes a bleeding problem. DIC can result from a lot of different things. Major trauma is the big one that your book talks about. It could be secondary to infection, especially septicemia. You may hear this talked about as an obstetric complication. So I've seen this with like an abruption of the placenta. I've seen this with amniotic fluid emboli, or even a retained product of conception or a retained fetus. Okay, so after a female has miscarried, I've seen this happen. You can see this possibly with neoplastic disease or cancer. I've seen this with tissue necrosis from burns. So a lot of different things can bring this on. It's not just trauma. It could be a lot of different things. So it's very important that we identify patients who are high risk for a DIC and be very alert to anybody who could be going into this. So signs and symptoms. So again, abnormal history or abnormal bleeding without a history of a serious hemorrhagic disorder can signal DIC. So what you're going to see is you could see oozing of the IV sites. Okay, that would be like abnormal bleeding. Okay, petechia. Okay, that's that pinpoint bruising. Okay, ecchymosis, hematomas, bleeding from the sites of surgical or invasive procedures. So, like I said, IV sites, but also like fresh incisions. Okay, I've seen this after a female's had a C-section, for example. Okay, the oozing over that site. GI tract bleeding. Other symptoms that you might also see: nausea, vomiting, dyspnea, oliguria, a complete urine output reduction, seizures, coma, shock, severe muscle, back, and abdominal pain, joint pain. And what you're going to see is you're going to see a progressive failure of your major organ systems. Okay, so that's usually what brings about the shock, the coma, and the death, is as those organ systems start failing. DIC is very, very deadly. Okay, so we have to be sure that we are watching for patients that we think are high risk of developing this. So we got to be looking for signs of bleeding. Okay, so again, as those clotting factors are utilized, you're going to start seeing the patient start having bleeding problems. So any individual who bruises very easy, petechia, blood in the urine, black tarry stools, any bleeding from the nose or the gum, or a new onset of painful joints. These are all signs and symptoms that we are watching for here. So here is a picture of hemorrhage into the skin. This is what I would call ecchymosis. Okay, very, very large bruising. Like that's abnormal. Like that's right over the flank area. That's into the abdominal cavity. That is not normal bruising, okay? So if you see patients like this, you need to be highly suspicious of DIC. So diagnostic tests. Your initial lab findings that support a tentative diagnosis of DIC are going to include like a PT greater than 15 seconds, a PTT that exceeds 60 seconds, fibrinogen level, it's not up there, but you need to know a fibrinogen level. Anything below 150 is indicative of DIC. Platelet counts below 100,000, and fibrin degradation products above 100, okay? ATI specifically asks you about their fibrinogen levels, so make sure you look that over. Any other things that you would look at? We would look at our hemoglobin level. I'm going to look at a creatinine level, okay? So a creatinine, because we're worried about those kidneys shutting down, I want to look at my BUN and my serum creatinine. And then we're going to do any additional diagnostic measures to determine the underlying disorder, because other disorders may cause many of the same results. And remember, this is not a disease itself. This is secondary to something else. So if you want the DIC to stop, you have to treat whatever is causing the problem. So again, just like I said, correct the underlying cause. So effective treatment of DIC requires prompt recognition and adequate treatment of the underlying disorder. Treatment could be supportive. So for example, when the underlying disorder is self-limiting, or it can be highly specific. So if the patient isn't actively bleeding, supportive care alone may reverse the DIC, but active bleeding may necessitate heparin and transfusion of blood, fresh frozen plasma, platelets, packed red cells, okay? Now, heparin therapy is very, very controversial, okay? It may be used early in DIC to prevent microclotting or as a last result in an actively bleeding patient. In thromboses, heparin therapy is usually mandatory. In most cases, it's given with transfusion therapy. So, like I said at the beginning of this is a clotting problem, okay? So the way that we treat clots is with heparin. If you give it at the wrong time, okay, it could be potentially fatal for your patients, okay? So that's why they say heparin is very, very controversial. But again, you have to understand, what is DIC? It's a clotting problem. So it does make sense in the early phases of DIC that we would give heparin to help with the issue. And then we're going to administer the blood, the fresh frozen plasma, platelets, cryoprecipitates, as we see necessary. So focused patient care is going to be on early recognition. We want to look at those primary signs and symptoms of abnormal bleeding, prompt treatment of the underlying disorder, and prevention of further bleeding. So to prevent clots from dislodging, we don't scrub bleeding areas. We use pressure, cold compresses, and topical agents to control any bleeding. You want to make sure we protect the patient from injury, so we enforce complete bed rest during bleeding episodes. If the patient's agitated, you want to pad the side rails. We're going to check all IV and venipuncture sites frequently. We apply pressure to injection sites for at least 10 minutes. We're going to monitor fluid intake and output hourly in patients with acute DIC, especially when giving blood products, and we're going to watch for transfusion reactions and indications of fluid overload. We're going to measure the amount of blood loss. We're going to weigh dressings and linens to record any drainage. We're going to weigh this patient daily, particularly if there is renal involvement. You want to check the patient for headache and assess neurologic status periodically, because they can bleed into their brain, and so we want to be assessing that neurologic status. We want to watch for GI and GU tract bleeding. So we're going to look at the abdominal girth. We'll measure it at least every 4 hours. You're going to monitor for any signs of shock. And you're going to monitor results of your serial blood studies. So we're going to look at our hemoglobin, our hematocrit, and our coagulation times. And we're going to evaluate the patient. So with successful treatment, the patient should be free from bleeding, and the test should show coagulation parameters and renal status within the normal limits. So we have to teach the patient, teach the family what kinds of things that we're looking for. And if we are dealing with fatality type issues, you want to provide emotional support. So we want to enlist the aid of a social worker, a chaplain, to provide the family and the patient with the support that they need. All right, and that will finish up DIC.